viewers, welcome back to Asan Network. I am your Dr.Salauddin and this is our fracture classification series. So today is the fracture classification series. The next important bone that we are going to discuss is the proximal tibia fracture classifications. Okay, so before entering into the classification, we will be discussing about the clinical anatomy. Okay, what is the structure of the proximal tibia? It's an articular structure with a tibial eminence or tibial spine in a triangular fashion. Right. In the lateral side, you have the fibula. So this is the structure of the proximal tibia from front. Okay, this is the tibial spine or the eminence, and this part is the lateral condyle. Lateral condyle of the tibia, and this is the medial condyle of the tibia. Okay. It is from the AP view. If you see anteroposteriorly, anteriorly we have a small tubercle called as tibial tubercle or tibial tuberosity, where the patellar tendon will be attaching. This is the patellar tendon that comes and attaches. This is the anterior and this is the posterior. And near the posterior aspect in the mid region, the PCL gets attached. Here the PCL, that is the posterior cruciate ligament, will be attaching. Okay. Anteriorly towards the medial side, the ACL will be attaching here towards the medial condyle. Okay. The ACL will be attaching here. This is the basic clinical anatomy that you should know before entering into the classification systems. And the tibia now is divided into three columns mainly. See, mainly the medial column, the lateral column, and the posterior column. So again, the medial and lateral column, they are divided into anterolateral and anteromedial, and the posterior column is divided into posterolateral and posteromedial. Both combined, there are totally 4 columns. In that, posterior column is treated as a whole, and posterolateral is supported by the fibular head. The posterolateral aspect of the tibia, proximal tibia, is supported by the fibular head. That's why any lateral column fractures or split fractures usually don't get much displaced because of the support by the fibular head. But the medial column or the medial fractures, if they are fractured, they'll usually get displaced as it has no much support. Okay, this is the column theory. Now coming to the classifications. The proximal tibia fractures, mainly the plateau fractures, the most important type is the Schatzker's classification. So the Schatzker's classification has 6 types mainly. We'll see the image. This is the Schatzker's classification, totally of 6 types, 1, 2, 3, 4 and 5, 6. The first one is the lateral split, the lateral condyle split. There is only split in type 1. Here it is lateral condyle split with depression. So there is a split along with a depression, that is in the lateral condyle. Then only depression. There is no split, only depression of the lateral condyle. It is type 3. Type 4 is medial condyle fracture. Type 4 is the medial condyle fracture. Type 5 is both the condyles are getting fractured. That's why it is called as bicondylar fracture. The bicondylar fracture. Then type 6 is metaphyseal dissociation. Any condyle with metaphyseal fracture. These are the 6 types in the Schatzker's classification. Now we will see how does these fractures occur, because the type 1 to 3, they are very low energy fractures because of the valgus force. Imagine these two are the legs. Okay, here is the knee joint. Okay, how is the valgus force going to apply? Distally, valgus, you can remember VALGUS. L is lateral. Okay, the distal part should go laterally. This is the valgus force. If the valgus force is applied, the lateral condyle of the femur, will get depressed or it will press over the lateral condyle of the tibia. I'll draw it separately. See, this is the femur, this is the tibia, and here is the fibular head. So if there is a valgus force and the tibia is bent like this, the distal lateral condyle will compress the lateral condyle of the tibia. That's why the valgus forces will cause split or split with depression or only depression. Okay. So, and 4 to 6 are very high energy traumas. The medial condyle, if it has to break, then it's a high energy trauma like in road traffic accident, etc. Okay. The clinical relevance is mainly that in type 1 to 3, only the lateral condyle part is damaged, so there is a chance of lateral meniscus injury. Okay. But in type 4, if the medial condyle is involved, then the popliteal artery or the popliteal nerve is getting to get damaged. Peroneal nerve and the popliteal artery is getting to damage. You have to assess these both. Okay. How you are going to assess the popliteal artery? By checking the dorsalis pedis artery pulsations, the popliteal artery pulsations, and the peroneal nerve. You are going to check. You are going to ask the patient to do dorsiflexion of the foot. Okay, because if the peroneal nerve is damaged, there is foot drop. Okay. Then type 5 and 6, it's high risk for compartment syndrome. This point you have to understand because the proximal tibia or the whole of the tibia, it is just subcutaneous. The tibia bone is subcutaneous. The medial aspect is a subcutaneous region. There is no much of muscles or soft tissue surrounding it. If there is a fracture, here posteriorly there will be vessels and no much of muscles and there is a skin. So if there is a fracture and there is oozing of blood, there is oozing out of blood, it cannot escape into the soft tissues. So there is swelling of the compartment here. The skin and the skin will get stretched. Whole of the compartment will get much pressurized because there is no soft tissue. If it's a closed injury and there is the blood oozing out, cannot escape anywhere. It increases the compartment pressure. This may lead to compartment syndrome. Okay. So how do you know if the patient is landing into the compartment syndrome? We call it as impending compartment syndrome. Impending means the compartment syndrome has not yet started, but it may leave. If you leave the patient, it will end into compartment syndrome. So what are the signs of compartment syndrome? It has 5 P's. First P is pulselessness. Next is paresthesia, pain out of proportion, paralysis, and pallor. Okay, these are the 5 P's in compartment syndrome. So in proximal tibia, there is more chance of compartment syndrome because it is a subcutaneous bone and it doesn't have any surrounding much soft tissue. So once the blood oozes from the fracture, it cannot escape into any area. It will start increasing the pressure within the proximal part of the leg. So it may lead to compartment syndrome. So which is more risk for compartment syndrome is the 5th, bicondylar fracture and the metaphyseal fracture, because both the condyles and metaphyses are rich in blood supply. These are rich in blood supply, so there is more oozing of the blood, so it has more chance of compartment syndrome. And in type 6, CT is mandatory for doing a surgical planning because along with the metaphyses, you have to rule out what are all the other bones that has been fractured. And mainly the depression fracture occurs in elderly because of osteoporotic bone. Okay, if it is an young adult, then there is more chance of split fractures. Okay, young adults, lateral condyle split fractures are more common. Elderly, because of the osteoporosis, the depression fractures are more common. Okay, this is Schatzker's classification. The one peculiarity you can observe is that Schatzker is telling only in AP view. Schatzker tells only in the AP view. He has not considered the lateral view. So another person came into picture and gave the coronal plane fractures, that is Holland-Moore classification. Holland-Moore considered coronal split fractures. Hence the first type is the coronal split fracture in Holland-Moore classification. So you can see posterior or anterior, if there is a coronal split, it is type 1. If the entire condyle has been fractured, the entire lateral condyle or the medial condyle is fractured, then it is type 2. If there is a rim avulsion, only a rim avulsion from the lateral plateau, only the lateral plateau rim part has been avulsed, then it is a type 3. Then there is a rim compression, there is only rim compression, then it is type 4. Then type 5 is 4-part or bicondylar fracture. Bicondylar along with metaphyseal fracture. Okay, it is Holland-Moore's classification. Here he only considers the coronal split fractures. That's why it is more important. The clinical relevance of the Holland-Moore classification is that it has high ligament injury association. That's why he tells to examine ACL, PCL and the medial collateral ligaments, and he suggests MRI in unstable knees to know the ligament status. Okay. Now coming to the AO or the proximal tibia classification. The number for alphanumerical classification for proximal tibia is, for tibia it is 4, and for proximal part it is 1. This is for the tibia and this is the proximal part. 1 is for the proximal part. So as you have discussed earlier in the AO classification, any articular part is divided into 3 regions: extra articular, partial articular and complete articular fractures. Similarly here also extra, partial and complete articular fractures A, B and C. So it has been a gold standard for documentation. So anyone doing a documentation on proximal tibia fractures, it's a gold standard classification. And 4.1c is a anatomical articular reduction is essential because it's a complete articular fracture and it forms the joint. So there is a requirement of anatomical reduction. And 4.1a may be managed with a minimally invasive approach. Okay, what is MIPO? MIPO full form is minimally invasive percutaneous plate osteosynthesis. This is called as MIPO, M-I-P-P-O, minimally invasive percutaneous plate osteosynthesis. Okay, if it is stable, then you need not open much. You can do a percutaneous plate osteosynthesis in 4.1a. So you'll see how many classifications are there in 4.1a, B and C. A is extra, B is partial, C is complete articular. So 4.1a, A1 is again divided. A is divided into A1, A2 and A3. So A1 is an avulsion extra-articular fracture. In A1, A1.1 is capsular avulsion. So 1.1 is the capsule is getting avulsed. If it is a lateral capsular avulsion, it is called as Sigon's fracture. Okay, Sigon's fracture is a lateral capsular avulsion fracture, and reverse Sigon is the medial capsular avulsion fracture. Reverse Sigons. Okay. Then A1, this is 1.1. 1.2 is the tibial tubercle getting avulsed. Anteriorly the tibial tubercle getting avulsed, you give it as A1.2. 1.3 is any cruciate ligament that is getting avulsed from the tibial spine. So most commonly ACL will get avulsed from the tibial spine. Then A2.1. A2 is a simple extra-articular fracture. Any simple can be divided into spiral, oblique and transverse. Transverse is less than 30 degrees from the horizontal. From the horizontal, if it is making less than 30 degrees, it is transverse. If it is making more than 30 degrees, it is oblique fracture. So oblique is 2.2, transverse is 2.3, spiral is 2.1. So this is A2. So coming to A3, A3 is the extra-articular wedge or multifragmentary fracture. So if it is an intact wedge, 3.1, the wedge is intact. Here the wedge is intact. If the wedge is getting broken, then it is 3.2, that is fragmentary wedge. If the wedge is getting fractured, it is fragmentary wedge, and if it is multifragmentary fracture of the metaphyseal, it is 3.3. So this is an extra-articular. Coming to 4.1b, that is partial articular. The partial articular in it is B1 is split fracture. So B1 split, if it is lateral plateau split, it is B1.1. 1.2 is medial plateau split, and 1.3 is involving the tibial spines with one of the tibial plateaus. Okay, medial or lateral plateau. The qualifiers, you add F when it is lateral, you add H when it is medial. Okay, so any of the condyle along with the tibial spine, it should be involving the tibial spine, then it is B1.3. B2 is the depression fractures. 2.1 is lateral plateau depression. 2.2 is medial plateau depression. The medial plateau getting depressed. In the depression also, if it is the column, anterolateral column getting depressed, you add T as a qualifier. U, if it is the posterolateral column. Central column is, you add X. Then anteromedially, you add W. Posteromedially, you add V. Posteromedially, you add W. And central, you add X. This is the qualifiers for depression fracture. Then the split with depression is B3. B3.1 is again lateral plateau. B3.2 is medial plateau, and if it is involving the tibial spine with the depression and split, it is 3.3. Again similarly, TUX for anterolateral, posterolateral and central, VWX for anteromedial, posteromedial and central, F for lateral and H for medial. This is split with depression. Then 4-1C is a complete articular fracture. So C1 is simple articular, simple metaphyseal. Both the articular and the metaphysis are simple. So C1.1 without any intercondylar eminence fracture. The intercondylar eminence is not getting fractured. It is C1.1 with an intercondylar eminence as a separate fragment. As you can see, the intercondylar eminence is a separate fragment. So it is C1.2. This is simple articular, simple metaphyseal. Now coming to C2, where it is a simple articular, but the metaphysis is wedge or multifragmentary. So C.2, it is intact wedge. 2.1. C2.2, it is fragmentary wedge, and multifragmentary is C2.3. Again qualifiers same, lateral and medial. So this is 4-1 C2. Coming to the final AO classification C3, that is fragmentary lateral, both metaphyseal and the articular part both are multifragmentary or fragmentary. If it is lateral plateau getting fragmentary, it is C3.1. Medial plateau, it is C3.2. Then multifragmentary medial and lateral, both the fragments are getting involved, it is C3.3. Okay. Here he gives if what type of area it is involving. You give it as anterolateral, posterolateral, anteromedial and posteromedial. Then if it is simple metaphyseal, multifragmentary metaphyseal, you give it as D and E. Metadiaphyseal extension, you add yes. This is the complete classification of AO. Now we will discuss a little bit about the tibial eminence fractures. Okay, where the ACL is getting attached and it is getting avulsed. So the ACL avulsion at the tibial eminence is given by the Meyers and McKeever classification. So the ACL avulsion is given by Meyers and McKeever classification. So type 1, it is an undisplaced eminence. You can see it is a undisplaced tibial eminence avulsion. If it is displaced tibial eminence, then it is type 2. Type 3 is completely displaced. So type 2, there is only anterior elevation. The posterior part is still, it is having a hinge. So in type 2, it's a posterior displaced anteriorly displaced, but posteriorly it is having a hinge, right? Both anteriorly and posteriorly, if it is getting displaced, it is completely displaced fracture. Complete displaced fracture, it is type 3. Type 4 is comminuted fracture. Okay, comminution, the fracture is comminuted, then it is type 4. This is Meyers and McKeever classification given for ACL avulsion at the tibial eminence. Right. Then the clinical relevance for this is it is more common in children, and ACL is the ACL avulsion or ACL tear is an equivalent injury. In adults, there is no eminence fracture or eminence avulsion. There is ACL tear. Right. In children, it is the ACL is very taut, so the ACL will avulse from the tibial eminence. So tibial eminence avulsion is more common in children. Okay, ACL tear in adults is similar to tibial eminence avulsion. So type 1, just immobilization is sufficient. In type 3 and 4, you have to do an arthroscopic fixation. The main risk for the children, it is knee stiffness because of continued immobilization. That's why after the operation, you have to do an regular knee exercises. Coming to tibial tuberosity fractures, the anterior tibial tuberosity, which is given by Watson and Jones classification. Watson and Jones classification, again modified by Ogden. So Watson and Jones, there are 3 types, mainly depending upon the physis. This is also given in children. Tibial tuberosity fractures is also given for the children, where the physis, if it is below the physis, then it is type 1. If it is through the physis, at the level of the physis, it is type 2. If it is above the physis, the fracture is above the physis, it is type 3. This is the simple Watson and Jones classification for tibial tuberosity. What Ogden added is only two types he had added. Type 1 or type A in Ogden is non-comminuted, and type B in Ogden is comminuted tibial tubercle fracture. So type A non-comminuted, Watson Jones type 1 is Ogden 1A. If it is comminuted, it is Ogden 1B. Similarly, at the level of the physis, non-comminuted 2A. At the level of the physis, comminuted, then it is 2B. Above the level of the physis, non-comminuted 3A. Above the level of the physis, comminuted, it is 3B. There is one more Ryu and Debehan avulsion type. It is type 4, where the posterior part of the tibial proximal tibia is getting avulsed. And one more type is McCoy and Steckency type, where it is called as type Y. So what is the clinical relevance in this is these are the adolescent athletic fractures. This is a sports injury where adolescents are getting injured, right? Then the extensor mechanism will get disrupted. So the patient or the adolescent will not be able to do full extension of the knee, or active extension of the knee is restricted. And similarly we have to do an compartment monitoring in tibial tuberosity fractures in the children. So early fixation will have an excellent outcome in tibial tuberosity fractures. This is the outline of treatment which was modified by Ogden. So if it is type 1, then you have type 1 to type 2. If it is less than 2 mm displacement, only knee brace is sufficient or long leg cast is sufficient, and reduction may be maintained for 1 week in control and immobilized for 4 weeks. Then protected extensor mechanism strengthening exercises for 2 weeks. Then extensor mechanism strengthening can be done and rehabilitation at 12 weeks, then return to sports. This is for type 1 and 2 with less than 2 mm displacement. If it is type 1B or type 2 with more than 2 mm displacement, that is comminuted fracture of below the physis, then type 2 is at the level of the physis with 2 mm more than 2 mm of displacement. We have to do an open reduction and internal fixation with metaphyseal screws or along with periosteum suturing, then followed by immobilization for 4 weeks with knee extensor strengthening, and then followed by strengthening of extensor mechanism, and then finally return to sports. Then type 4 above the physis, any type, it is open reduction and internal fixation with metaphyseal screws. Then type 3 and type 5, we have to do an MRI or orthotomy to rule out any meniscal injuries. Okay. Then here also open reduction with epiphyseal or metaphyseal screw and periosteal sutures. If there is a meniscal injury, then you have to do a meniscal repair. Similarly, the immobilization, the strengthening exercises, and then return to sports at 12 weeks. This is the reference from which I have taken. You can enter the DOI code and you can look into the paper for tibial tuberosity fractures. Now coming to physeal injuries in children, where the Salter-Harris classification is given for physeal injuries for the tibial physeal fractures, right? So there are 5 types of injuries. I'll draw and show. This is the physis, right? So type 1 is through the physis. So the first type, the fracture is going through the physis. It is type 1, right? Then type 2, it is above the physis. Above the physis in the sense it goes into the metaphysis. The fracture goes into the metaphysis. Type 3 is it goes below the physis. In the sense it goes into the epiphysis. The fracture line goes into the epiphysis, right? Then type 4 is through the physis. Physis above and below means all through from epiphysis to the physis and then to the metaphysis. This is type 4. Type 5 is it is superior and inferior crush injury. Okay, so I will draw the diagram so you will understand better. So type 1 is through the physis. The fracture is going through the physis. Here is the physis. So type 2, it is in the metaphyseal region. So I will draw like this. Okay, this is the type 2 fracture. This is the 1. You can draw the numbers. So here I have drawn the number 2 fracture where it has come through the physis and then above the physis through the metaphyseal region. Okay, so in the metaphysis there is this fragment forming because of the fracture. This fragment is called as Thurston-Holland fragment. So in type 2 you have Thurston and Holland fragment. In type 3 it is below the physis or the epiphysis, the fracture going like this, right? So I'll write 3 like this, reverse 3. Okay, so the fracture is going through the physis and into the epiphysis. It is type 3. Type 4 is type 4. You can see the fracture is going through the epiphysis, the physis and the metaphysis. Okay, so this is type 4. You can remember and you can draw the number 4 on type 4 Salter Harris. Type 5, it is superior and inferior compression. So the physis is getting compressed because of the sudden superior and inferior compression. What happens in each type we will see. So type 1 is through the physis, type 2 is physis and metaphysis, type 3 is physis and epiphysis, type 4 is metaphysis and epiphysis, type 5 is crush injury. In X-ray, the one point you have to remember is you cannot differentiate type 1 and type 5. You cannot differentiate type 1 and type 5 in X-ray. How you can identify type 5 then? Type 5 is always retrospective diagnosis. What does this mean? Retrospective diagnosis. It means that the injury has happened now and you may not notice in the X-ray. Further in the future there might be growth plate damage restrictions. The growth plate may have damage and there is growth restriction in the limb. The limb may be shortened. Then you have to do a retrospective history. Then the history may tell that he had a facial injury before the shortening or the deformity has occurred. Then you may know that there was a crush injury at that time. So it's always a retrospective diagnosis. For the type 1, it is through the physis. There may be, it looks similar to type 5. So type 1, you can diagnose at the time of the injury. So the clinical relevance of this is type 3 and 4. You must always require an anatomical reduction is mandatory because it involves the articular area. Both type 4 and 3, it involves the articular area as epiphysis is involved. So anatomical reduction is mandatory. Type 5, because of the crush injury, the growth plate is injured, so the growth arrest is very much at risk. So hence you have to follow till skeletal maturity. This is the Salter Harris classification for proximal tibial fascial fractures. Okay. So proximal tibia, there is metaphyseal fracture. There is a named fracture in pediatric age group called as Cosen's fracture. Okay. What is this Cosen's fracture is? You can see in the image. It's a metaphyseal fracture of the proximal tibia in children or pediatric age group. Why it is important is it occurs in very young children and it will cause a late valgus deformity. That this deformity is called as Cosen's phenomenon. Okay, so hence it will require a long-term follow-up. This is the image showing the Cosen's fracture, that is proximal tibia metaphyseal fracture. Okay, it is similar to torus fracture in distal radius, right? Unicortical fracture in the distal radius. You can see there is only mild cortical breach. It is not completely fractured and completely displaced. Okay, what it will cause is, because of the growth deformity, it will cause a valgus deformity. So this is it is going laterally. It's called as late valgus deformity, and this is called as Cosen's phenomenon. That's why you have to always follow the proximal metaphyseal fractures in children, because he may develop a Cosen's phenomenon, and you have to prevent this late valgus deformity. How you are going to prevent this late valgus deformity? By doing closed casting and deformity reduction. You need not do a surgical correction. Closed casting and deformity correction is enough. Okay. So in children less than 3 to 6 years, the Cosen's fracture is more common and it's a metaphyseal fracture. In 8 to 14 years, there is tibial eminence fracture, that is axial avulsion, which is similar to adult ACL tear. Okay. In 12 to 16 years, the tibial tuberosity is more commonly fractured, and there may be because of the growth spurt and or the jumping injuries. The classification given for the tibial eminence is Meyers and McEvers. Meyers and McEvers classification. For tibial tuberosity is Watson and Jones with Ogden modification. Then in young adults, it is Schatzker type 1 to 3. Because of the sports valgus injury, it is more common. In high injury, Schatzker's 4 to 6 is more common because of RTA or fall from height, and in elderly, the depression fractures are more common because of the osteoporosis. The high yield points is in type 4, that is the medial condyle fracture. You have to always think of vascular injury. The popliteal artery may get injured. Then in bicondylar fractures, you always get a CT to do the surgical planning. Then in type 6, it's a high energy and a soft tissue damage is present. Both soft tissue should be preserved, and there is more chances of compartment syndrome. So you have to watch for compartment syndrome in type 6. In the tibial eminence, there is paediatric equivalent. Tuberosity fractures, it is an adolescent athlete or sports injury. Then Cosen's, it has Cosen's phenomena or late valgus deformity. Okay. If you like this content, then you can check out more classification videos in my playlist or in my channel. You can click and you can see all the other classifications. Okay. If you like this video, please like, share and subscribe to your colleagues and be confident in your clinical rounds. Thank you.